Good evening. Good evening, everybody. Welcome in Oman Society of Nephrology Scientific Program. We have lecture every 2 weeks. Today, our lecture is very excellent lecture, as our speaker is one of the famous nurse in Sultanate of Oman. Regarding she is the stone corner or stone corner in the peritoneal dialysis in Muscat and the Royal Hospital, Sister Nadya AlRahbi. We are known the peritoneal dialysis in Royal Hospital and accompanied by Sister AlRahbi. And today we are very interesting and we are waiting this lecture, and you can start, Sister Nadya. Thank you.
Assalamu alaikum. Good evening, everyone. Hope everyone doing fine. Today, inshallah, I am going to present about one of the important lecture regarding peritoneal dialysis. So, how to establish successful peritoneal dialysis program. I am going to go through these points, which are a background of current situation of peritoneal dialysis worldwide, history of chronic kidney disease and peritoneal dialysis in Oman. Number 3, why peritoneal dialysis is still underutilized, and why we need a well-established PD program in Oman. Key factors for high-quality PD program. And we'll end it with our conclusion. So PD or peritoneal dialysis remained underutilized worldwide, even with many studies showing that the advantage of peritoneal dialysis and giving a better quality of life, in the same time also providing similar survival outcome when compared with hemodialysis. So worldwide, there are only 11% of people using hemodialysis of the people who are requiring dialysis, and more than 50% of this 11% just living in 4 countries, which are China, United States of America, Mexico, and Thailand. Here we have one example of those countries, which is Mexico. So if we see my red markers, I put the PD utilization, and this is done in 2020. The peritoneal dialysis utilization in Mexico was 59%. And most of their patients on peritoneal dialysis using automated peritoneal dialysis. The interested point here that the nurse to patient ratio is 1 to 3. So 1 staff looking after 3 patients only. And their follow-up once every 1 to 3 months, depends, I think, on the patient's conditions. And the most important point here is the cost per year for PD is less than hemodialysis. If you see the slide here. Going to the next country, China. Why China has better or more utilization of peritoneal dialysis? According to a study here done, 2014 showed that the utilization increased from 8.6 from it was in 2000 and jumped to 15.5 in 2012. And the centers, it were only less than 10 centers, PD centers, to 700 in 2012. And that due to a policy initiated to improve kidney replacement therapy access. Here in this slide, this table, I want to show you there is a good relationship between the income status and PD utilization. This is a study done in 2021. And if you see here the color code, for example, the orange showing that 0 PD utilization, red showing 1 to 10, green 11 to 15, yellows 26 to 50, and blue more than 50%. If you see here in Africa, which suffer from poor and the poor income or low income, in many countries in Africa, the BD utilization is 0. Going to other countries, if you see the blue here in NIC, which is newly independent status, and Russia, there is a good utilization of BD, and there is also in some countries, on some centers, more than 50%. And also in Asia, if you see here in North and East Asia, there is a good number or percentage of utilization. Now, coming to our Oman, the chronic kidney disease and peritoneal dialysis in Oman. Okay, so here, many studies done by our doctors here in Oman and nephrologists showing that the yearly prevalent counts of a new patient treated for end-stage faced rapid increase. And for example, it rose from 1,535 in 2008 to 2,051 in 2015, according to Dr. Ismaili study done 2021. So the prevalence rate increased from 463.5 to 670.1 per million population. And there is something interesting, that there is a sharp rise in the incidence and prevalence of end-stage kidney patient with age, increasing with aging in Omani population, especially after 45 years of age. And this study done also by Dr. Ismail, this is the same one. Okay, here, according to Al-Ismaili study done 2017, showed that the incidence during 1983 was very low. It was only 21 per million population, and it's gradually increased to 75 per million population in 2001 and 120 per million population in 2013. Again here, according to Intisar Al-Alawi, which done the study in 2017, focus on the also percentage of end-stage kidney disease population in this group from 45 to 64 years. They have the more incidence of reaching end stage. Now coming to peritoneal dialysis, if we see the Oman peritoneal dialysis utilization rate from 2018 to 2022. By the way, I got the information of hemodialysis numbers from Dr. Yaqub Al-Maymani, and the number of PD from Dr. Shada Raisi. She is the head of an NCD. So the number of patients of peritoneal dialysis from 2018 until 2022 remain equal, the same, the utilization. There is no much difference. Remain between 9, and only in 2019 increased slightly to 10.5, which is less than the global utilization. Here, this is for report for in July 2023 for patient distribution among nephrology centers. That means the patients follow up in this center. So in July 2023, the total number was 262. Adult patient we have 229. Pediatric were 33 patients. We see here number of active centers were 7 almost, or 8 centers. We see here the number of patients more in Royal Hospital, 85, with 29 patients pediatric and only 56. And the big number were in Nizwa with 73 patients, and they have only pediatric 4. Also in Ibri, there is a good number with 48. and the others remain slightly improving. I think now September the number had increased. I don't have the statistics. Dr. Tariq?
ايوه معاك يا استاذ نادية، اتفضلي.
Okay, clear?
Very clear.
Now we'll go to the important points. So why peritoneal dialysis is still underutilized, even with the studies, many studies showing that it's reporting a better survival and more quality of life. So we have different reasons. We have different reasons or factors, but we'll focus on 4 factors. They are the most important factor for underutilized of peritoneal dialysis. The four factors, first one is governmental policies and financial encouragement. Number 2, psychoeconomic barriers. Number 3, knowledge and experience with peritoneal dialysis among nephrologists. And number 4, technique failure. So of course, we'll start with governmental policies and financial barriers, because the governmental policy and the money is considered as the pyramid, the high of the pyramid, of course, the head. So what's going under government policy and financial barriers? Poor government support. Of course, the government the support will not be less unless due to some factor like finance situation, and they are not able to provide BD consumables. Number 2, lack of reimbursement for BD in private sector, limited access to peritoneal dialysis modality to the public healthcare system. And number 3, lack of peritoneal dialysis promotion by government. Okay, here are some strategies done by some countries to overcome governmental and cost barriers. For example, in India, they have begun to manufacture peritoneal dialysis solution locally to reduce the cost of purchasing peritoneal dialysis from other countries. And you know, it is not only cost money, it's consuming time, and they have to wait for because it's coming by ship, so it will take long time, especially here. I am talking in Oman, for Oman, at least 3 months. Number 2, United States. So what it done in United States, they following the introduction of reimbursement strategy in 2010 to motivate dialysis provider to place more patients on peritoneal dialysis, and that had increased the percentage of peritoneal dialysis from 9.4 to 12.6. Number 3, in Thailand, what's done in Thailand in 2008, the government implemented a step to introduce a policy to promote the use of peritoneal dialysis as initial mode of treatment. So within 3 years, the centers increased from 51 to 111 centers, and the percentage of patients, the utilization increased from 10% only to 45%. So what this policy involved, first of all, training for the medical person. Without the training, you cannot establish a good program. Number 2, they developed a policy and guidelines providing insurance covering. Okay, you know, the peritoneal dialysis, it's expensive, so they provide insurance. And they established a renal registry to monitor practice and patient outcome. Number 2, for the reason why BD is still underutilized, is psychoeconomic barriers. So under this cause, if there is a lack of availability of suitable housing, we cannot accept the patient, especially if they don't have a space to store PD solution with other consumable, and also they don't have a space to do the type of dialysis. And also if they have lack of adequate sanitization, how they can do, and especially this type of dialysis required hygiene. And the most important factors related to lack of availability of housing, water, and electricity. We cannot accept patients who is using water not connected, I mean water. They use it from outside or not clean water, because this is reported increased risk of peritonitis. So the second reason is all patients which bias healthcare provider from referring them to peritoneal because of higher comorbidities and low cognitive ability, unless they have good family support. Manual ability. Of course, this is also required special care and support from family and society. Always or many old patients, they suffer from poor vision also, so they cannot handle peritoneal dialysis unless they have also good support. Number 3, about the knowledge and experience with peritoneal dialysis among nephrologists. So many nephrologists are feeling uncomfortable to consider peritoneal dialysis as an option for a patient who reach in this stage, because they don't have the enough experience and skills, knowledge to handle this type of modality. And because in the early experience of peritoneal dialysis faced some problem with infection, peritonitis, inadequate clearance of small solute, and also there is a damage of the peritoneal membrane. So this led to decline of BDUs. Number 3, technique failure. So the most common reason for technique failure decrease the utilization of peritoneal dialysis is the death, number 1. Of course, if you take, usually we are encouraging cardiac patient to go with peritoneal dialysis because it is gentle and smooth, but those patients, they are high risk for death. That's why sometimes we are losing a lot of patients, beside other factors, of course, elderly patient and others. Number 2 is infection. Number 3, inadequate dialysis. Of course, with experience, you can manage the dialysis, the clearance and prescription of dialysis. And of course, number 4, mechanical and patient-related factor. The mechanical usually related to technique of surgical and also other reasons. Regarding patient-related factor, usually a patient with high body mass, with high BMI, they have high risk to transfer to hemodialysis, high risk to get more peritonitis, and also exit site infection. Also, some studies show that the non-white race, lower socioeconomic status, and patient with the comorbidities such as diabetic. The most important here also factor causing technique failure is patient preference, and that one due to the mental illness. Even if the mental patient, good support, good family support, sometimes you cannot manage because of due to their mental illness. Sometimes they will pull the catheter, sometimes they will disconnect the catheter. They will do something cause infection or trauma or failure of peritoneal, or maybe refuse to do the dialysis itself. Number 2, inability to tolerate the number of treatment sessions required by BD. And here we focus on the pre-dialysis education. So if you explain very well about the peritoneal dialysis, how it's work, how many sessions you required, how many hours, it will be clear from your side. But if it is not done properly, and the patient will be shocked with the daily dialysis, and for example, with the automated peritoneal dialysis, 10 hours, really, patient will not accept. So especially if the patient were on hemodialysis and he was doing only 3 times per week or 2 times, and you will move him to everyday dialysis, he will not accept unless from beginning, you have to do very well education about that. Number 4, loss of support network. Maybe the patient has good family support, for example, or he has good caregiver, but he lost that caregiver due to different reasons. For example, his daughter who were taking care of him get married, or the private caregiver left him and no other one. So, for example, so this is the reasons for technique failure. And here, this is this graph according to the study done. According to this study, it's showing again the same thing. The reason for technique failure done in one of Europe country from 2012 until 2017 showed that the death or stop dialysis is the first cause of technique failure, followed by infection, and number 3, clearance or ultrafiltration problem. Here some strategies. Here's some strategy to decrease risk of peritonitis, for example, in the early stage. So before, while preparing the patient for peritoneal dialysis catheter insertion, it is recommended to give operative antibiotics, for example, vancomycin. And number 2, we need to give thorough training for the patient and education from the beginning of the starting peritoneal dialysis. Number 3, home visit is very important also for your side to assess the situation of the home. How is it? If you just listen to the patient and he's telling that my house is good, sometime really he's feeling his house is good and he has good space and his house is clean. But if you see yourself, you have different, for example, view regarding that one. So if you do home visit in the beginning, you can give advice for the patient. You recommend him to do some certain steps to be accepted. Number 2, focus on the hand. Number 3, focus on the hand hygiene. At least during the 5 to 8 days training, every day you focus on the hand hygiene. Also, train your patient, your staff or your nurses. Don't depend only on one nurse. So you have to train your nurses who's working on peritoneal dialysis, and also utilize or use mupricin or gentamicin as prophylactic to prevent exit site infection. Okay, and also identify from the beginning while you do assessment for your patient. See or identify the patient who are more risk for infection compared with others, and focus on the training for them and retraining regularly. Here also there is one important point is treat depression as a peritonitis risk factor, because if the patient is depressed, he will not take care about hygiene, maybe he will not do his therapy in regular way, or he will do anything which can harm him. And the last step, demonstrate hand washing technique with glow gear. If you have it, this one will be good, because you will show your patient, he feel his hands clean. Why I have to do all these steps and why I have to spend 2 minutes to wash my hand? Show them how many germs or bacteria in your hand if you washed with normal hand washing, which you are doing in daily. And compare it with the aseptic hand washing, which you have to follow before starting peritoneal dialysis. He will feel and he will be convinced that it's really very important. Here are some strategies also in the latest stage, retraining. Retraining is very important after peritonitis, after prolonged hospitalization more than 5 days, after exit site infection or tunnel infection. And also you can do it annually for all patients as elective. Prophylactic, like oral fluconazole or nystatin, if the patient spent more than 5 days on antibiotics. And also, if the patient going for colonoscopy or any gynecological procedure, so it is recommended to give prophylaxis also. Avoid constipation, hypokalemia, gastroenteritis, and diarrhea, because this is cause high risk for infection. And also, if the patient infused contaminated dialysate during, for accidental disconnection of the catheter or touching by hand, accidental touch, or he used fluid with leak. So in this way, if if the patient reported this, you have to give him prophylactic antibiotics. Okay, now why we need a well-established PD program in Oman? We have three main reasons. I focus on them. PD is one option of renal replacement therapy. This is his right to select peritoneal dialysis, patient right of self-decision making. So if you, of course, with collaboration with the team, if he's fit for peritoneal dialysis, so this is his right to go ahead with it. Number two, because of the advantage of peritoneal dialysis, and number three, because of the issues and complications of hemodialysis. For example, here I will go about, this is the common and well-known, and many studies reported that the peritoneal dialysis give early survival advantage and can preserve residual renal function for a long time. Easy to manage at home compared with hemodialysis machine. It's easy to handle and manage if there is any issue with the machine. And also the patient feel independent. Number four is lower risk of hepatitis C, and we know some cases they got this hepatitis due to the during hemodialysis. Also, PD reported better quality of life because he will feel more free. He has a chance to live his life like normal, like others. He can continue his work and his study. And also some studies reported that peritoneal dialysis is giving more control for blood pressure and volume. Okay, here we'll focus from the real situation, what's happening in issue with hemodialysis in Oman. We had a big number of peritoneal dialysis in Oman. If you count the utilization, I think we have more than around 90% utilization. If maybe less 1% or 2, not more than that. So that one led to fully occupied hemodialysis. And I got the number of centers from Dr. Yaqub also. So we currently have 27, and most of the centers are full. So also because of the number more, we shortening dialysis session, and of course, instead of 4 hours, we are giving 2.5 or 3. That will lead to inadequate dialysis. And instead of 3 sessions per week, we are giving 2 sessions, and also it's lead to a complication or an inadequate dialysis. Also, chronic patients dialyze in acute centers because they don't have space in chronic center fully. So we are utilizing the acute centers. And of course, in acute center, we cannot offer full sessions with the full timing, usually. More patients on hemodialysis, of course, will increase the cost. Number two, long distance from patients' home to hemodialysis centers. And I will give the example now what's going on in Muscat area. Patients, for example, from a SEEB area, they have to, a new patient, of course, I'm talking, they have to go to Al-Amirat because other centers are full. And they have to wait until one of the patients, for example, moved from dialysis due to whatever reason. Number four, there is no flexible dialysis schedules. I think also, at least in the beginning, for students and working patients, they cannot select their time. I want morning, or I want afternoon, or I want night. You have fixed time. Maybe they can offer for you later on this suitability, but especially in the beginning, what I know, you cannot. Okay,
yes, Sister Nadya, yes, regarding your speak about SEEB we will starting night, maybe within 1 month, due to increase in number of
Yeah, I
patients.
am talking about what's going on this last, yeah, a few months and years. I know from last year what I know. Yeah. So maybe we can get solution, but I am talking about the current, what's going on.
Yes, yes.
Okay. Okay, so the last points, key factors for high quality PD program. And it's very important to know the key factors to success in PD program. Number one, dedicated and experienced PD team. If you have confident and commitment PD team, automatically the PD program will be grow. This team contains of nephrologist, surgeon, microbiologist, of course, PD nurses, nursing team, dietitian, clinical, pharmacist, social worker, and dialysis item distributor companies. Everyone is working. All the team work together to achieve one goal, which is successful peritoneal dialysis program. You cannot work without, for example, pharmacist or nurse or company, and of course, surgeon or doctors. Number two, for the key factors for high quality PD program, pre-dialysis education. Pre-dialysis program or education aim to provide education for the patient who reach in this stage or who are on the chronic kidney stage 4 or 5. Give them all information and give them the time for, allow them to decide their treatment by themselves. Of course, with collaboration with the team and see the suitable treatment. The best time when the patient reaches stage 4 and 5. So what is the impact of pre-dialysis education? Promote shared decision making. Here, you will allow the patient to be aware about his current condition and decide his treatment. Number two, start early preparation of permanent access. Either patient selected hemodialysis or BD or transplantation, this is the best time to prepare them. And for example, if he selected hemodialysis, we'll refer him early for AV fistula creation, and we know the long scheduling waiting. So this is a good chance if we educate our patient early and they decide early. Reduce the risk of emergency dialysis and temporary vascular access. And you know the consequences of emergency dialysis and temporary vascular access, of course. Increase selection of peritoneal dialysis patient. If you educate the patient from the beginning before starting hemodialysis, you will get more patient who selected peritoneal dialysis compared with the patient already he is stable in hemodialysis. So why you want to disturb them unless they have some complication or issue with hemo? Early preparation for kidney transplantation and increase preemptive transplant. Reduce admission rate and costs, and this is well related to the point, which is starting emergency dialysis and temporary vascular access. Reduce, and our doctors, they are exhausted really, especially the on-call team. So it will reduce the pressure on the team. How many cases they have to put acute catheter? How many patients coming attended emergency because of requiring emergency dialysis? Of course, if the patient, I'm talking here, if the patient have regular schedule in the CKD clinic, if the patients come with, and there is no follow-up, this is something else. How to make successful peritoneal education program? Start early education. Don't wait the patient until already he is fully shortness of breath and hyperkalemia, and that time you will do education. No, start education early during the stage 4 and 5. Sit with him and his family talk in calm or quiet area, explain, and give them chance to think. Use proper communication skill. Reduce your level to patients who their education level is low. Even you can use their language if you know how to speak Swahili or Belushi, or if the patient is young, go to his level. If the patient is old, also go to his level. Don't depend on one material for education. Use verbal, non-verbal, audio, visual also, and depends on the expert patient. What I mean of expert patient, select a good patient on peritoneal dialysis, doing fine, and he has the good communication still to convince other patients. And for example, in Royal Hospital, we selected one of the best patients who can convince others. So always we are depending on two, I think, patients who can convince others, especially if the patient is fit for peritoneal dialysis. The last important point is continue regular follow-up with your patient until decide for his final. For example, patient referred, doctor nephrologist from clinic referred the patient to you as a specialized nurse to explain the education about all. You have to follow with them. Put a note of that patient. I have to call him after 1 week. I will give him a chance. I will give him appointment to again the clinic, pre-dialysis clinic, or I have to give him a call. Don't ignore if the patient he did not answer. Don't call him. No, call him once, 2 times, 3 times, 4 times, until he gets convinced and decide for his final plan. Who are responsible to educate patients? Of course, the first line nephrologist who run a CKD clinic. Then the specialized nephrology nurse take the bulk of the work because he has the room with all facilities and he have more time. Doctor will see 50 patients or 60 in the clinic, but you have to see maybe 4 or 5. So the nurse need to spend time in the meeting room with all educational materials, explain, demonstrate, and also clinical dietitian, pharmacist, and social worker. They have their own part they have to focus to train the patient before starting dialysis. The content of pre-dialysis education, usually we need to, first of all, we need to explain the current situation of renal function. How you have to explain for them where you reach, how much your percentage of renal function work, your renal function is. Also explain the the choices of renal replacement therapy, all options in details, and also tell them about the importance of early decision and preparation compared with emergency to make them fit, because some patients require time to make them fit for certain therapies, either hemo or BD or transplantation. And also they have to know the importance of diet restriction, blood pressure and sugar control to delay the dialysis stage. Number 4, tell them also about the consequences of late decision and emergency dialysis. Number 3 of key factors for high quality BD program, proper BD infrastructure facility. If you have good full BD team, if you established pre-dialysis education, but if you don't have proper infrastructure structure for the peritoneal dialysis, you cannot run the BD service. So well-planned, equipped, and organized PD unit, including educational, training, treatment section, considered one of those important factors. So the infrastructure include room for training, room for follow-up, and office, usually. We'll start with training room. Training room, usually all educational materials, TV, video, tables, all teaching aids should be available in the training room. Dressing set, because you have to do practical and demonstration. Patient, he has to do in front of you, demonstrate the exit side dressing and also full steps of dialysis. You need also other all mentioned here, heparin, IV fluid, material for exit site care, disinfectant solution, mask, etc. And also the presence of sink, liquid soap, and clean towels is necessarily in the training room for hand washing. Characters of training area should be calm environment. All the equipment functioning well. There are some teaching aids available in the room, and the light should be quiet. Use single room, special room for training. Don't train your patient in the cubicle. Follow-up room, like any follow-up to examine your patient. You need hand washing, sink with all facility, examination, bed, chair, vital signs equipments, weighing scale, personal protective equipments, and others all necessarily need to examine your patients. Office, clinical office, you need a computer connected to a hospital system like a Shifa we are using here in Oman. And now if you're using the Baxter BD solution, you need to connect computer with a net for online monitoring, which is BD clinical software. So you can monitor your patient every day from that computer. Patient's record, including prescription, schedule, training appointment, etc. BD audits and statistics, and also forms administrative regarding development of your BD service. Regarding number 4 is techniques for BD catheter insertion. Don't rely or don't depend on one method of peritoneal. If you want to increase your number of patients, if you want to speed the number of patients on dialysis, on peritoneal dialysis, so with increase of number of patients going for peritoneal dialysis, it is recommended to use different method for peritoneal dialysis catheter insertion. Local sedation proved to be a good alternative for high-risk patients who are unfit for general anesthesia. If the patient unfit for general anesthesia, don't tell him, no, you are not fit for BD. You have to go for hemodialysis. We have to get an alternative, which is local. Now, Dr. Khalfan offering to do percutaneous BD catheter, of course, local. So this is a good chance. Percutaneous BD catheter insertion under locker is faster way, and this is from our suffering here, because patient who is going for general anesthesia, he has to wait for cardiology clearance after 3-4 months. He has to wait for anesthesia clearance. He has to wait for slot surgical. We don't have slot. We have a lot of emergency cases going for surgical. Required high-day bed or ICU, no bed for 1 week, you have to wait. Every day patient is fasting, first day, second day, third day. Fourth day, he will tell, Ma'as-salam, I am going. I cannot be fasting for whole my life. And of course, if you do percutaneous, maybe you can do more cases within 1 day. If I'm talking our situation, you cannot do more than one case under surgical slot because they have there are many cases who require really emergency dialysis or more serious than critical than just BD catheter insertion. Number five, for key factors for high quality program, this is very important, continuous quality improvement. If you don't have this, you cannot evaluate your program. So first of all, you need to do a training program, regular training program for your staff, nurses, doctor, whatever, who's working with this target of patients. You have to have BD registry, include all details about peritoneal dialysis patients, include rate of infection, dropout rate, etc. So this registry will give you the chance to evaluate and plan to correct the obstacles or complication you face it from, for example, last year or last 2 years. Of course, governmental policies to support PD. This is my last slide, summary and conclusion. There are different factors for PD under utilization. In some countries, the governments are not supporting because they are feeling hemodialysis is the best. Some due to the cost. Some they want to focus on transplantation, for example, and different factors which I explained previously. Awareness of peritoneal dialysis as applicable dialysis method should be increased among nephrologists and healthcare workers. Don't tell I am only with hemodialysis. No, this is the patient right to be aware also to have a chance to go for peritoneal or for other things. Dedicated and experienced PD team, structured patient training program, continuous patient support, establishing and utilizing standardized protocol, monitoring continuous quality improvement. This is all factors and improve the successful PD program or lead to successful PD program. PD registries can be an important source of data to inform continuous quality improvement research and health care planning. Government support is the one of the main factors for supporting PD program. Thank you. If you have any question, please.